welcome to the folks on Zoom. I forgot this was a hybrid event. Okay, so going back to the Singapore Research Nexus, the website also has a collection of Singapore-related creative work. Okay, and this includes novels, poems, plays, and short films, all written by FASS faculty and students. And one of the, I think, the richest resources we have is actually a photo bank of pictures of Singapore by the FASS community. And these pictures, if I'm not mistaken, Rachel, they are actually available for anyone to use, right, in your own research. So it's really useful for kind of visually showcasing some of the themes, you know, which you may want to highlight from your research. SRN also publishes weekly highlights of FASS research pertaining to Singapore, and it organizes regular events like this one. This is actually the 4th of our policy outreach series, and our 5th is scheduled for next March. So maybe just to highlight a couple of upcoming events. There's one happening in January. This is organized by a new research cluster we have at FASS. It's called the G.L. Lewis Religious Pluralism Research Cluster. So basically it's about interreligious kind of harmony and diversity. Okay, so this is actually going to be held at the Shaw Foundation Alumni House, and you can register by checking on the FASS website. Yes, thank you. Then secondly, also in the earlier part of the year, in February, we are having the Global Research Forum. Okay, and this is an international conference that is organized by who's this? Professor Derek Wojcik. I'm sure I've got his surname wrong again. He's from the Department of Geography. And the topic of the international conference is on geopolitics and the geoeconomics of finance. So as before, you can go to the FASS website to register and find out details. This is in February 2025. And thirdly, we will have another policy outreach event, this time on the theme of environment in relation to policy in Singapore and the region. This will be held in March 2025, and you can check the Singapore Research Nexus website for more details. So these are the 3 events that we wanted to highlight for your calendars in the new year, actually. We're nearly at the end of the year now. So on that note, I'd like to wrap up and introduce our chair and moderator, Associate Professor David Allen from the NUS Yong School of Medicine, who is also a research presenter at this event. David Allen is Deputy Executive Director of the Center for Population Health at the National University of Singapore. He's also a Senior Consultant in the Division of Infectious Diseases, Department of Medicine at the National University Hospital, and Associate Professor at the School of Medicine, National University of Singapore. So I will leave David to introduce more to you some of his initiatives. Thank you.
Thank you very much. Thank you to the organizers for inviting me to participate. I'm looking forward to the discussions. We've got 4 talks. We've got diversity. I'm the old person, since this is an aging and there'll be 20 minutes with 10 minutes for questions. I do hope you'll be interactive and probe our speakers today. I'm looking forward to the dialogue. So without further ado, let me introduce our first speaker, who's Assistant Professor Zhang Xiaohai, who's in the Department of Communications and New Media at NUS. His research primarily looks at communications and technology and how it can improve people's health. Xiaohai, please.
Good morning, everyone. It's my great honor to share one of my recent projects about e-health in older adults. So the title of my presentation today is the descriptive norm and the e-health use among older adults, a cross-country comparative study. My name is Xiaohai Jiang. I'm an assistant professor in the Department of Communications and New Media at NUS. So just give you some background of the study. E-health, right, is playing an important role in promoting population health. So what is e-health? It broadly defined as the set of technologies that provide healthcare services or health-related activities with the help of the internet. So in general, e-health is the use of technology and the internet for health-related purposes. Right? So for example, you can use your wearable device to monitor your health condition. You can also do an online consultation with your doctors, and you can use the a mobile app and patient portal, for example, electronic health records to check your treatment progress. You can search for health information online and also other services such as health education, diagnosis, and therapy from the internet. So e-health is particularly important for older adults because it can satisfy some of their healthcare needs. A high demand of healthcare and assistance due to suffering from more health problems in older adults. They are facing, for example, multiple chronic disease and mental health and physical health problems. And they can receive healthcare services online, and they can also engage in community online to receive social support without the constraint of time and the space. Despite the importance of the e-health to older adults, we do see the low e-health adoption rate among older people. So for example, in one study in the United States, only 12% of older adults have used the health app. And this usage rate gets lower as age increases. Another study in China showed that only 9% of older citizens have used e-health services, despite most of them already have internet access. In Singapore, a smart nation, among the technology users aged 60 years old and above, fewer than 1/5, right, 21% have used digital technologies for health-related purposes. Given the low adoption rate, a big question for us is what factors influence e-health use in older adults? So let's look at the existing literature in this line of research. There are several major lines of existing literature. First, it focused on personal characteristics such as education, age, income, and access to ICT. So most of the studies examine the influence of demographic factors in public health research, and in communication research, we use the digital divide theory to understand the effect of access to technology and their influence on technology adoption. Another line of research emphasizes enhancing e-health literacy. So the argument here is that the interventions aimed to boost digital literacy is considered to be very effective to reduce barriers associated with technology use. However, if you look at the existing interventions, many of them are not successful in promoting e-health use, particularly sustain the e-health use in older adults. And some study examine the main effect and the direct effect, ignoring the mediating mechanisms. So what I mean here is the process of technology adoption and diffusion is complex and dynamics. It is not that straightforward. You educate them, you give them skills that they immediately will pick up the technology. So we need to understand the process, underlying process in between. So what happens first, followed by what stage, and finally, this will lead to the adoption. Right? So this underlying mechanism is largely ignored in the existing literature. And also, most of the studies conducted in one single country, while lacking the cross-country comparative perspective. To fill this research gap, we make the following contributions to the existing literature. Additional factors beyond personal capacities need to be taken into account when promoting e-health practices. We argue that social influence should be considered, specifically social norms. Social norms serve as the social cues to help older adults' decision-making about e-health adoption due to the high level of uncertainty associated with e-health. For example, technology, complexity, privacy concerns. So our argument is the social norm can help us to overcome challenges associated with this uncertainty. Second, we aim to identify mechanisms underlying the process of e-health adoption. Specifically, we test the mediating role of social norm, attitude, and self-efficacy. Thirdly, we conduct this study in 3 countries, including Singapore, United States, and China. We argue that country variations, such as culture, might exert influence on e-health adoption. For health communication research, we consider theory-driven approach is very important. In this study, we use the theory integrative model of behavioral prediction, IMBP. The core tenet of the theory is that one's actual behavior is a function of behavioral beliefs that are initiated by external stimuli. So you need to take into account both the external factors as well as internal factors. The reason why we use the IMBP is that this is a very effective model to predict health behaviors. According to some meta-analysis and systematic review, this theory can explain a substantial portion of variation in health behavior outcomes, ranging around 20 to 30%. And it theorizes the key mediation mechanisms, including injunctive norm, attitude, and self-efficacy. And also, cross-country variation have been implied in this model. However, it is under-researched in this line of research. The cross-country comparison can help assess the predictive power of the model across contexts and populations and help us to advance theories. So the definitions for our focal variables in our study, distributive norm refers to the belief about the extent to which a particular behavior is prevalent in our social system. So people usually rely on behavior of the majority to guide their own behavioral decision-making. So for example, if we say in the community, right, more than half of people have already adopted e-health use, then this is considered to be a distributive norm to influence their willingness to adopt. Injunctive norm refers to a perception of the behavior being approved by reference, and they specify what should be done. So injunctive norm reflect a social pressure to comply with reference, and it implies the non-compliance may incur social sanctions. So for example, if your family members, your close friends, and your peers in your social network all encourage you to use e-health, they say it is important to use to protect yourself and also to help the family and your community, right? If most people encourage you, suggest you do that, you are more likely to adopt. Attitude is one's belief about the degree to which performing a behavior will be positive or negative. For example, the positive outcomes associated with adopting e-health. Okay, and the negative consequences if you don't use e-health to protect yourself, right? So this is about the attitude. And finally, self-efficacy is one's belief in the ability in performing a certain recommended behavior, right? It's more about one's confidence in taking action. So this is the model we proposed. So the distributive norm, right, which is the prevalence of the behavior will increase people's perceived injunctive norm, and to facilitate more positive attitude, increase one's confidence. And these 3 will have more direct influence on e-health use. Okay, we also compare the country difference. We conducted online survey in the 3 countries using Qualtrics online panel. There was some inclusion criteria: people aged 60 years old and above, and be citizen or permanent resident in their country, and have internet access, because we test the e-health use. So we consider internet access as inclusion criteria. So we have around 500 participants in each country, and we use the process macro for data analysis. So this is our measurement, so you can have a more concrete idea about how we operationalize these concepts. Okay. So for example, the majority of people who that similar to you already use e-health technology. So this is the descriptive norm. Injunctiveness, people who influence you, people are important to you, think you should use e-health technology. Attitude is about how you view e-health. And self-efficacy is about how comfortable you use technology on your own, and if there is no one around you to help, you can still use it. And e-health use, actually, we include 9 health-related activities, including look for health information, make medical appointment, talking to your doctors, using wearable devices, purchase medicine online, and so on. Okay, this is our participant characteristics. So you can see there is slight variation in terms of age and gender, right? So some difference. And regarding the, you can see the distribution norm, China and Singapore, you can see they have higher level than the US. Injunctive norm, similarly, Singapore and China have higher level of norm. And attitude, similar, right? Self-efficacy, these are also similar. So e-health use, surprisingly, China has higher level. Maybe one reason is the people, the participant in the China sample is slightly younger, right? In their early 60s, and the US is in their 70s. So that's why there is some variation. So for our hypothesis, all the paths are supported, right? So that means the distributive norm increases e-health use, and also it increases injunctive norm, attitude, and self-efficacy. And these 3 in turn actually increases e-health adoption. But the most important finding comes from our comparative perspective. So as you can see, there is country difference, right? So first, regarding the main effect of the distributive norm, we can see it is significant and positive in Singapore and China, but not in the US. And for the injunctive norm, it is significant in all the 3 countries. But regarding the mediation effect of attitude, we found the positive and significant role in Singapore and the US, but not in China. In contrast, and the mediating effect of self-efficacy is significant in China, but not in the US and Singapore. So let me give you more interpretations of this specific result. Regarding the first finding about the significant effect of descriptive norm in Singapore and China, but not in the US. So our argument is that while individuals in the US have stronger sense of personal autonomy, they express themselves outside the constraint of social roles, those in Singapore and China tend to view themselves as socially constructed and have a higher level of identity identification with their social groups. Right? In contrast, individuals in the US might emphasize their independence, and people in Singapore and China, on the other hand, are more interdependent on each other. And so that's why this type of social bond and deeply influenced their e-health adoption, right? Injunctive norm is significant in all 3 countries, right? So these highlight that in both the individualistic and the collectivistic cultures, injunctive norm can play a significant role, right? So this, remember, this is how people around you, okay, think you should take actions, right? So this influence is actually significant in 3 countries. Regarding the attitude, we found that it is significant in Singapore and the US, but not in China. So this result is quite interesting because in the existing literature, we found that people from individualistic culture tend to be more self-reliant than those from collective culture. So you can see they explain the personal attitude is quite important in US, but not significant in China. But interestingly, right, in Singapore, we also found the important role of personal attitude. So this, I think, we can consider the cultural difference, right? Singapore might be have very unique mixed culture, a combination of the East and the West. Okay, the final result is the self-efficacy. So we can see this is significant in China, but not in Singapore and the US. Right? So this is quite inconsistent with the culture theory, which suggests that individuals from more collective culture pay less attention to this type of belief when making behavioral decisions. So to explain the difference, we need to take into account the different contextual situations in the countries. So for example, compared to US and China, in the Singapore, so Chinese patients might receive less support from their health providers due to the relatively shortage of medical resources, also due to the more conflicting doctor-patient relationship in China. Okay. And also, the overall health literacy and e-health literacy is lower in China. So that's why self-efficacy becomes more important. Right? So empower them to activate them to use the technology. Okay, lastly, I have some implications for practices. So we need to tailor our e-health promotion based on district norm. So we need to emphasize the prevalence of e-health adoption among peers and community members. We need to facilitate the normative influence, particularly in Singapore and China. So for example, if we have some community, we do see some increasing adoption, array of this, then we can use this type of data to show the wide adoption, right? And to influence the other communities. We can also leverage the injunctive norm and attitude self-efficacy. So for the injunctive norm is the perceived approval of e-health use. So this highlights the importance of their family, their friends, right? So we call for more intergenerational communication when promoting e-health technologies. We also incorporate the peer support in the community, right? To influence older adults to adopt the technology. And we need to facilitate positive attitudes, right? The perceived benefits and what are some negative consequences if you don't take actions. And finally, we need to build confidence, right? So we can set up the role model and we can use testimony to increase older adults' confidence. And we can play a more concrete plan for them to start to learn and to really adopt the technologies step by step. Okay, and also we should take into account the country-specific mediators. So in Singapore, we can highlight the social acceptance of e-health technologies and also the positive personal attitude. In US, we can promote the personal positive attitude as the key driver of the e-health adoption. In China, we need to build up their confidence through self-efficacy building initiatives, such as training and the user-friendly design in e-health tools. And overall, we should have a more culture-sensitive, normative-based interventions. So we need to consider the individual attitude, community, and family endorsements in different contexts. My last slide is about some specific strategies we can use. So for example, we can encourage influential groups to endorse e-health. Healthcare providers should take a very important role for advocating e-health use to patients. Social media influencers are also very important because older adults, they also use social media. Based on our research, they use YouTube very often. They also use Facebook and WhatsApp very, very often. And community leaders and local celebrities, right? For example, if they trust some local, like the influencers, for example, TCM practitioners or faith leaderships and so on, right? So these can play a role in endorsing e-health use. We also call for awareness campaigns at the beginning, at the early stage of e-health promotion. We need to provide evidence-based benefits and also to address their concern regarding security and privacy. We want to use real-life stories from individuals who have experienced the positive outcomes. And we want to build confidence through training. So we provide tutorial videos and demos, and also this user-friendly design and local e-health workshops. We combine both online and offline, these platforms and better design of the technologies. And finally, we highlight the importance of family and peer support networks. Right? So facilitate this family's role for long-term sustained use. Because after the intervention, the workshop, they might immediately pick up the technology, but in the long term, they might forget or they might have lower motivation. So that's why family can continue to support, and also the peer, these mentorship programs can also help the long-term adoption. Okay, so that's the end of my presentation. This is my email. If you have any question, feel free to email me. Thank you very much.
Thank you very much. That's quite interesting. Are there questions to begin with? Otherwise, I'll start off with one, which is, this is not my area of expertise, but I'm fascinated by this because I'm aware of the anxiety and the campaigns about, I get messages all the time about being aware of various agents
Yes.
and scams. How does that complicate?
Yes. So in our study, right? So this type of a scam really triggered an anxiety, right? But if you have the social support or the social resources there, and social resources can help overcome. So our study highlights the importance of social influences. So that means when you are faced with this misinformation or this type of emotional responses, anxiety, if you have this type of normative influence or the social resources to help, I think it can lower their concerns and promoting more willingness to adopt. Yeah.
And do you know of the different programs or targeted efforts, if those are being applied currently in Singapore or in China or US?
Yes.
And if anybody's actually measuring
Many of the this type of e-health literacy intervention really focus on the technology skill set and their knowledge training, right? While the social aspect is not widely incorporated into their intervention studies. So that's why we see this type of campaign is not very effective because people do not have their social resources there to support them.
Yeah. Yes, please.
There's one interesting I catch on your assumption that Americans are individualistic and Singapore probably to a large extent also individualistic, and the Chinese side is collectivist.
Yes.
That assumption.
Yes, because we try to use the culture to help us to explain some of the findings. So because we do see a huge difference between US and China in our study. And Singapore data, some similar to the US, some similar to China. So that's why we, when we interpret the results, we think maybe Singapore is actually in between. Yeah. But I mean, this is just our proposed explanations. We didn't actually directly check the specific cultural factors or the specific, for example, the media or the political factors.
Because your explanation is dependent on a often assumed perception that Americans are individualistic and Chinese are collectivistic. But historically, and if you look at the kind of a philosophical foundation of, let's say, Western thing, and the Chinese side, if you look at, let's say, the writings of Confucius and Mencius and so on and so forth, and the religion that was prevalent in China, Chinese indigenous religion, religious practices, like if you go to temples around this region, Taoist temples, they're all individualistic. But Western religion, Christianity, for instance, is collectivistic. You go to the same mass, you go to the same thing. And so I think that if your explanation is dependent on an assumption, it's just an assumption, that needs to be defended in the first place. Now, how can you build your explanation on a very shaky foundation?
Yes, so we basically use Hofstede's this cultural dimension. That is the cultural difference at the national level. Yeah, I think at the individual level, I agree with you. People might be different, right? And even in the more individualist culture, and they also have more collective belief due to the religion, this type of belief. Yeah, I think you give us a new direction for future research that we need to actually examine these cultural specific factors in different countries. For example, the religion, and see how this will influence our results. Because the assumption we have might not be very valid or accurate unless we do have the empirical evidence to show, okay, the religion might influence their health belief or their attitude. Yes, I think that's.
I think, I just want to also push you a bit on this, right? Because it's almost like you have a theory and then you applying that theory to your findings. But the Singapore case in particular actually challenges your theory. Singapore, it's like, I mean, the way you described it, right? It's like some of it is individualistic, some of it is collectivist. So initially when I guess maybe I wasn't listening so closely and I wondered, who were your kind of the people that you sampled, but they are older adults, right?
Yes, 60 and above.
This is where, as a Singaporean, I really struggle to think of that generation as individualistic. Because if you talk to local Singaporeans, our parents are very reliant on us, to help them make appointments, remind them, navigate e-health, etc. So I would say actually from the findings you have using the Singapore case, you can even challenge the theory.
Yeah.
Again, as Paul said, to rethink that assumption that societies necessarily fall into these kind of categorizations. Yeah.
Yes. So I think for the next step, we want to more specifically examine the social influence. So how family and other social network might influence their role, right? So in this study, it's just a very general examination. Yeah, but thank you for the suggestion.
An opportunity for collaboration with sociology.
Oh, yes, yes.
Any other questions? Yes, please.
Thank you for the great presentation. I'm Ozan Kuru from Communications and New Media. So I'm interested if you consider in this line of research the importance of ideology and worldviews and broader technology adoption attitudes, because we have individuals, particularly in the elderly generation, who might prefer their alternative health, organic food movement, those who want to take, they don't want to do anything to do with digital life, people who in their midlife take digital detox. Part of it like that, but part of it also relates to the broadness of the term e-health. It includes many different things. There are some things we can consider that promoting in itself greater adoption has very strong foundation, like gaining information. But on the other hand, when it comes to wearable technologies and trackers, how is it really applicable that in and of themselves for elderly individuals? Just like they should get their vaccines or their regular checkups, is it that important that they have wearable technology trackers adopted, and how it connects to their, conservative or more different ideologies that might seek more purist view about their health. They don't want to have anything to do with technology constantly tracking themselves, right?
Right. I think this is an area that is really under researched. For the ideology and the worldview, right, we see these type of influence in their vaccination and these related behaviors. But in terms of the e-health adoption, I don't recall any study examining this type of influence. Yeah, they might. Yeah, I think we have the worldview survey, right? It's also a cross-country survey. I might want to take a look at that survey and see whether the worldview really influence the e-health adoption, because what is the rationale behind this? It's not very clear. So I think that's another very promising field for future research. Thank you. What's that?
Any questions online?
Yes,
Excellent.
there is a question on Zoom from Daisy Eng.
You read out the question for us.
So the question is that the multicultural study is the right direction. Good job. Besides social influences, need to also consider type of medical insurance paid. Okay, yeah, by stay versus self-pay. Yeah, so in this study, unfortunately, we didn't measure their medical insurance coverage. I think this is about also the whole system, right? Because you can see the different health insurance system in different countries, and it's about the policy perspective. It's about the healthcare systems. So I agree. This type of health insurance system might influence, for example, whether people can afford these online services, because some system might include the online consultation into their coverage, while other system might not, right? So I think the health insurance system will make a difference if it, but yeah, in my study, I didn't actually have this variable. Yeah, but I think for our health communication research, we want to have more ecological perspectives. So not just personal and the social, right? We also want to see the system, right? Also the policy. But in this study, unfortunately, we didn't tackle other perspectives. But I agree to have a more comprehensive understanding of factors influencing e-health adoption, more levels of influences should be taken into account. Yeah, thank you, Daisy, for the suggestion.
Any realms that you would like you're seeking collaboration with?
Oh,
This is an opportunity to,
yes.
whether it's on the policy side or whether it's on the.
Yes, as I mentioned,
research side.
from my existing research, I rarely consider the policy perspective. I start to look into more social perspective in my recent research. So I think if you are interested in technology from the social and also the policy perspective, I'm willing, I'm happy and eager to collaborate and seek potential research collaborations.
Excellent.
Thank you very much.
All right, thanks. Our second speaker today is Associate Professor Feng, who is in the NUS Department of Sociology and Anthropology and Assistant Dean for Research at NUS Faculty of Arts and Social Sciences. His research fields are aging and health, population studies, and economic sociology. And he's going to speak to us today regarding how measurements matter in aging and health studies.
It's really my pleasure to have this chance. Actually, when I was asked to join this, Ying told me that better present something new and useful for the policy making. I really cherish this opportunity. I want to firstly highlight three very brief points in general. First of all, for academics and policy, particularly in terms of aging, we probably will have to start from the biological, medical, clinical knowledge and translate to social policy. And we have very different layers to face with the culture, the history, community, the family, and then human beings and the individual behaviors. So exactly because of that, social science matters, I think. And number two, I want to say within medicine and within social science, this integration already happened. Actually, right after Second World War, I mean, medicine already proposed this so-called social cycle medical models. And then within sociology and social science, this kind of integration, particularly between the quantitative study and qualitative study in order to understand health, also is an ongoing procedure. And certainly I want to say, we're in Singapore. Singapore is a role model for many, many societies. The medical system in Singapore is always ranking at the top in the world. And that's why any innovation, any reform in Singapore, we need to, a lot of countries look upon Singapore. And then the most recent movement about healthier Singapore basically is trying to highlight the integrated and preventive strategy of addressing health in the population level. And that actually gave us another chance to promote this kind of integration, to merge with social science and medicine and all together to address the aging and health study. And that's why today I'm thinking about this and I'm trying to say, what is my main message I want to deliver to this forum? This is the message I would like to deliver, which is about measurement. I think measurement, we are just using it very, in all of our study, both scientific, social science, medicine, clinic, and particularly in aging and health. We are depends on many different kinds of concepts, and we operationalize it, claim we are using certain kind of measurement. But when we usually adopt those measurements in line with the routine literature, and then assume it is good practice, and we publish the paper. But I think we really need to reflect about this, because measurement for academic routine will facilitate our communication. But when it translates to policy making, it may create some troublesome situation. What kind of message we are trying to deliver to the public and academics actually depends on how careful we are in terms of explaining the measurement. I firstly give you an example. This is right after COVID. And this is the ranking for Global Health Security Index made right before the COVID. Okay. So that means that you are better in this index, you are better to prepare for health crisis. And this is published right before COVID. And then this is the real outcome of COVID, the orange. Can you see? It's almost opposite. United States ranked, UK ranked number 1, number 2 in this health security index. But look at what the performance is in terms of real. What is the message is we take it for granted that something should be measured in this way, and then we make some big mistake. And why are we saying this? Let me start from this example. Today I have 5 very simple examples to show it to you. I don't have, let's say, time to talk about the real research, but I want to deliver the message that measurement is so important. I mean, for my medical colleagues, disability is kind of a routine measurement. We have the ICF, this disablement model by WHO. So basically, when we talk about disability, I mean, aging, the essential part, why aging matters is because people are disabled, right? They're impaired, they cannot move, therefore they cannot be labor force, they need care. So disability is at the core of the whole story. And this is the conceptual framework about disability. And we all understand that disability starts from some kind of functional body impairment and then translate to your activities and then translate to your social participation. So this is quite clear. And then when we do research about disability, we tell Singapore policymakers that, oh, disability increase, and therefore you should be prepared. So that's kind of the common language. But if you're not careful about this measurement, this is what we find in China. We find out actually in China, disability, when you ask people, do you have difficulties in doing this and this? It is actually better, improved. But when you really objectively test them, can you stand up? Can you pick up a book from the floor? is worsened. And then actually when I do this paper, and people are very confused about it, how come the two trends are very different? I give you a very simple explanation. You know, one study in Taiwan actually showed that within 10 years, Taiwan's IDAL actually improved greatly. And we check why. It's because they asked, do you have a difficulty in making a phone call? And that 10 years is because of cell phone introduction. It's exactly not because of body at all. So then what is the message you tell the policymaker disability trend is increasing or not decreasing? What are you really talking about this? I mean, this is really confusing. So I mean, as researchers, we really need to analytically separate them out to tell the true story. Okay, that's my first point. My second point is, this is a real story. Well, I work with my colleagues at Duke AOS, and he told me, hey, Feng, you know, I found something is wrong. We found when Singaporeans are old, this is Singapore case. When Singaporeans are older, they are having less social support. Oh, this is a bad news for our society. How come? Singapore is a good society. Older people are well being taken care of. How come we find that when they are older, they actually receive less and less social support? I say, as a sociologist, I have an answer. So let me check how you measure. This is a measurement from America. And people in America ask, do you know these people? Very often, or some, or a lot. And then you have a score. When you apply this to Singapore, definitely, I think Singaporeans will say, there's a limitation. Where's the mate? Right? Firstly, that's the limitation. And then the second question is, seriously, will mate be counted as social support? Seriously. And the third one is, look at this. You are copying me, you have these people, the total score, but actually, they are actually counting the scope of it instead of the intensity. And then when we further do the analysis, we found, oh my God, yes, in this index, Singaporeans older, you have less social support. That means your scope of receiving social support reduced within family. But the intensity actually increased, but your measure did not measure it. And that's why when you deliver this, telling government when people are getting older, they have less social support. What are you really talking about? Okay. First of all, this is American index. It's not localized. And second of all, you are missing the most important culture of Singaporeans, family and intensity. This does not capture at all. So we have to use some statistical skill to say, oh, probably that conclusion is not very solid. We need to see the real structure issue. Thirdly, this is another story in Singapore. And I work with Cohen Pei at hospital. We use her data and to find out something very interesting, because living alone is kind of a very popular issue picked up by policymakers, and older people living alone, that is bad. So basically, but when we analyze this, I said, no, I don't want to work on a paper that everyone knows the answer. People are living alone is bad. Yeah, according to this, very simple statistics, they are more likely to be socially isolated. But the majority of Singaporeans who are depressed or socially isolated come from those who are living with their family member. So you are telling the policymaker, oh, those solo laborers, they are in danger. You need to take care of them. You are ignoring a big chunk of social isolated people who are living with their family member. And that's why our paper is living together, but emotionally apart. That's a real problem for Singaporeans, rather than only focusing on a small group of solo laborers. And in regard to this, I would like to further challenge this. This is not published, but super interesting. Me and Professor Telling Ling, we go to a community. I said, I see a lot of Singaporean older ladies, they are living alone, but very happy. So I don't think living alone is really a factor that definitely lead to social isolation. So probably in your community, let us separate them to see what's really going on. So we have the common people living there with their family. We have a group of solo livers, and then we separate to firstly, never married, and secondly, widowed. Those people who never married are even better in all kinds of dimension in comparison with normal older people. I checked with them, who are they? They're usually the first generation of Singapore lady who start to have chance to be educated and choose to not get married. And exactly because they are not getting married, this, husband will not be a barrier for them to make friends. They are super active in the community. And look at all these scores, they are better. So when you talk about solo liver, you are actually making an average of the super good and super bad. And you tell the government that all living alone is bad. That's the wrong message. Okay, that's what I'm talking about. This is my third story. Okay, just as short, I'm also interested in digital gap. We just finished this survey. Singapore is really good. I mean, in terms of all kind of ranking, like Singapore, everyone got a cell phone, and someone got 2 or 3 cell phones. Okay, right? And then you rank Singapore. I mean, in terms of the digital gap criteria, Singapore is always #1. But then I'm asking, how do you measure digital gap seriously? People use, do you have a cell phone? Or do you get on internet? Well, I see, do you really think that's enough for Singapore older people? Is there a deep layer of digital gap? So some of the older people actually are forced to use cell phone because their adult parents asking them to take care of grandchildren. Say, mom, dad, please take the cell phone. I call you, you just reply. And then the people don't know how to use e-health or app. They are forced to use it. But in your measurement, there's no problem is done at all because they have cell phone, they use WhatsApp. But they never watch news. They never use e-health. Okay, they never learn. I mean, in that regard, I'm in my digital gap, but because my son, use a lot of fancy apps online. I don't know. I think digital gap is a constantly changing term. And if you just use digital gap definition without any reflection, you're in a trap. And that's why we develop an ideal domain of digital gap. For example, we ask, do you learn? Do you want to learn? Okay. And if you use cell phone, what is the usage specifically? Okay. And then we see, oh my God, we see only about 20% of Singaporeans are ideal users. Okay. About more than 70, they are in the gap. They're in the gap. Or in comparison with the standard of international, 90% of Singaporeans are not in the gap. We identify 70% in this regard. We need to move on. That's my full story. Okay, the last story, sorry, take time. The last story, this is my early work. When I first came to Singapore, I focused on China, but with time passing by, I really want to work on Singapore. And then for Singapore, what is the top ideology about the future aging world is successful aging. Successful aging. It's in the policy. The government say, we want a successful aging society. The marker is different generations will be harmoniously living together, respect with each other. And this is society for all the ages. Well, I really love this idea. And then I was trying to, as a sociologist, I say, well, of course, the core part of it should be, the core part of it should be medicine. Professor Nin Ziping and his team published this in 2009. Exactly before I came to Singapore, I was really appreciate this work because this is really the baseline according to the international standard of measurement to see how Singaporeans are successful in their aging journey. And this idea is very simple. You need to be disability free. You need to have good cognition. You need to socially participate. You need to be satisfied with your life. So all these criteria filtered. About 30% of Singapore older people, they are successful. And I mean, international comparison, according to the international comparison, this is a good number. It's a good number. So this is the message we deliver to the government that in terms of the international standard, we're doing quite well. About 30% of older Singaporeans, they're successful, right? But let me ask you, as if my colleague, my anthropology colleague will ask this question, it's not that rare that if you ask an older woman or older man lying on bed, they cannot move at all. You check with them, you happy? You think your life is successful? Yes. And then you telling me that I'm listening to the doctor, you are not successful. How come you feel successful? I'm successful because I have a successful son who is taking care of me. And for me, life is good. And you are trying to use a professional view to say, no, according to the medical standard, you are not successful. But does lay person have a right to say yes or no, successful, unsuccessful? That's the basic human right, exactly, right? So what I'm saying is medical measurement might not be wrong, but you need to think the other way, how people think about it. We just check with different Singaporeans. We have a survey, checking with them, what do you think is good criteria for successful aging? Yes, I mean, the majority say like, I should be happy, I should have no disease, no disease. This is very common sense, this part. This is just like a medical definition. However, about 80% of Singaporeans say, I need to have my spouse with me. I need to have my children. I even want them to be living with me. This is my criteria. More interestingly, about 90% of Singaporeans say, independence is very important for me. And about 70% of Singaporeans say, dependency is very important for me. You add them up, it's more than 100. So that means at least 40–50% of Singaporeans say independent and dependent are both important for me. If you are using the measurement, you cannot find this. What are they? They are the Singapore fathers and mothers. They say, I don't want to be burdened, right? For my children. I want to be independent. On the other side, I want to be dependent when I need it. Like coexist. Framing idea of the very Asian style of what is successful aging. And this should be the message listened by the government. Not only take the biomedical way as social science, but also respect the lay person's perspective. Okay, so I'm having I don't have time, but this is the very last one. I want to just show this is a recent case. We just follow the medical data to see if you have disability, how soon you're going to die. This is the dying curve. And these are the people who have disability saying, I'm not happy at all. I know I have disability, okay? And I'm doomed. And these are the people who don't have any disability and happy. But if for people who have disability, but they think, I don't have disability, I can deal with it, they're here. So I'm trying to say combining medicine and social and psychology will provide a more refined picture for policymakers to do things benefiting everyone in this society. Yeah, thank you very much.
Very nice talk, thank you. I'm left thinking that everything I read is wrong or can't be trusted. And that on the other hand, I can manipulate data to present in whatever I want. And that policy is the result of science or knowledge gone through a filter of political science to meet one's needs. Okay. Are there any questions? Yes, please.
So looking at the living alone and not feeling, happy, that sort of thing. And feeling socially connected. I was thinking that when among the Singaporeans, whether you isolate people living in landed and people living in HDB. And so in HDB structure is the void deck and the kopitiams are a very nice socializing places. If you go to the kopitiam, you see older folks drinking and having talking, and that most likely probably they live alone in their own flats. And so they are socially connected, but then of course they live alone. If you are in landed place, so probably it would be very difficult to do, and it would be more comparable to, let's say, the American population.
That's very interesting. Yeah.
I do not know whether you have that kind of.
First of all, I dream to have that kind of data. Now social survey can rarely interview people who live in the condo. We cannot get in. So most of the social survey are actually collected from the HDBs. Second of all, Professor Ball, this is super interesting. I mean, who are really disadvantaged in older life? Are those socially advantaged, social economically advantaged people living in an isolated environment? They are socially relatively probably disadvantaged instead of poor but live in a very good community friendly environment. That's very interesting. We should work together on that.
Can I just add to that? But actually, this is a real policy gap, right? Because when it comes to social connectedness, most of our government ministries, like HDB, for example, will look at what's happening within the HDB estates, etc. But to them, landed estates, it's not under our mandate at all, right? And then if you think about, say, MSF or MCCY, they always want to look at the most socially disadvantaged groups rather than so-called richer people. So this is a real policy gap, but actually what Tom says is so true because, so as a geographer, who's done interviews with different kinds of people in different living arrangements, right? It is really the people who are in landed estates that are at risk of being the most socially isolated because the transportation connectivity is not as good, frequency of shuttle buses, walking distance, etc., which means that once they reach a certain frail stage, right, and they can no longer drive, they can no longer go out independently, they are really just stuck at home. So this is a real policy gap, but seems to me that there's no government agency that's taking this up. Yeah. Because they are rich, so-called. So why should we care? Someone else will take care of them.
By the way, Eileen, I want to add on your point. Actually, when I think about this, I want to bring your case to my case. Aging in place and aging in
networks, yeah.
I mean, aging in place is exactly a routine measure for gerontologists. Namely, we should promote people to age in place. But Eileen's project is actually change this to see place is actually essentially network. So it's also a kind of in line with this type of translation to policymakers. What is really aging in place? It's actually aging in network.
Aging in multiple places, especially in a place like Singapore, where different parts of Singapore are very well connected. So people who live in those parts of Singapore, they're able to go around easily, meet up with friends in different places, have their social activities, etc. Right? So currently, our policy imagination really restricts aging provisions to the neighborhood.
Yes,
which in the project which Vincent and I did, instead we trace people's social networks and we found that people are aging in multiple places and the neighborhood itself is insufficient. It actually makes them prisoners of space. And this is a policy assumption that continues to be perpetuated. Yeah, sorry, FAS has been really challenged.
Because I'm coming purely from a medical perspective. So when I discharge someone from the hospital who can no longer live independently, family can no longer take care of them at home, and they're placed in a nursing facility, is that necessarily, is one of the filters saying it needs to be in a community where you already have social connection, or are we now dooming you to a more rapid decline, isolated and frail?
So I think, when we look at this kind of interventions, we actually need to look at age cohorts, right? So for someone who's already in a frail state, yes, the neighborhood facilities are functional, right? It's the most convenient, the most practical. But for younger people or even older people in their 80s who continue to be healthy enough, they want to move around. So if you say to them, I'm going to assign you to a rehab center that's closest to where you stay. They may say, oh, but I actually don't like the staff there. I don't like the people there. And I actually prefer the services in another place because my friends have told me about it. But then I don't know how the medical kind of subsidies, etc., work, right? If they want to go to use a rehab facility in another neighborhood, for instance, are they able to enjoy the same kind of medical subsidies? I'm not sure about that. Yeah. But I think in the research project that we did, right, because we did GPS tracking. So, I mean, by disposition, you may say that that project is already biased in terms of collecting information on mobile people. But we also did interview people who were using PMDs and electric wheelchairs. And what really came out in our project, right? This was a survey with about 1,200 older Singaporeans, and then in-depth qualitative studies, right? Is Singaporeans who are still mobile or desire to be mobile, actually the idea of choice autonomy matters a lot to them. So sometimes when we say we just need to make sure that the neighborhood facilities are good enough for them, but that may not necessarily be what is most fulfilling to them in terms of their social desires. So that's the societal aspect, which I think in particular with newer estates, for example, at Dawson, there are some parts in Dawson which are quite well connected to public transport, but there are also pockets of it, which are further away, there are fewer buses. And so for people who stay in those areas, right, they have to wait longer, and arrange their schedules around the bus frequency, for instance. So the quality of aging, right, is different even in the neighborhood in terms of people's ability to go further out.
We have a question from online from Anonymous. Moving forward, how would you suggest for us to explore perspectives of successful aging among future generations of older adults?
Okay, I firstly hope I can get more grant to do this.
Are you sure?
That's an appeal to everyone in the room and outside the room. Okay.
Yeah. For me, successful aging should be a changed idea. For different cohort, they may have very different ideas. I mean, for the current cohort of Singaporeans, they are the baby boomers, and they already go through this very tough time of economic rising up, and they are not very educated. But very soon, we are going to see a new cohort. They know the e-health, they know cell phone. They will have a very different demands. So how to define successful? We need to do more research to understand from the lay perspective. That's right. Yeah.
Any last questions? Yes, please.
Thank you for the great presentation. So past retirement age, many elderly continue to work in various ways, like volunteer work. Is there any measurement data that might show how they are faring compared to in terms of well-being and health to other groups? Because
Yeah. I'm having a product called productive aging. Yeah, and it's highly also related to aging in network. And basically after retirement, we do observe Singaporeans have a very different choice. Some of them continuing to work. And there's a common misunderstanding that when the tourists came to Singapore, see a lot of older aunties work, older taxi drivers, they say, oh, Singaporeans, older people, they're not be happy. But if you do a little bit investigation, you'll find many of them are not working purely for money. They're saying something like, if I go back home, I watch TV, I got brain issues. That's kind of a very unique local culture. Namely, after retirement, and then people think work will be beneficial for their health. You cannot see this in Shanghai, in Seoul, or even in America. This kind of very unique ideology. Second of all, I want to say, according to our survey, I mean, the average retirement age people expect it to be is kind of 75 to 80 in their mind. Much later than the current one. So this is a layperson perspective. Okay.
Very good. Thank you so much. Our third speaker is Dr. Yap Kwang Shia. She's in the NUS Department of Pharmacology. She's a research fellow at the Memory, Aging, and Cognition Center. Her work focuses on real-world evidence and experiences of vulnerable population with an emphasis on implementation of community health interventions. Thank you very much.
I'm from the biomedical, so let's have a conversation today. So I will be speaking on some of the studies that we have in our center on the early detection and multi-domain interventions for dementia prevention. Just a brief introduction for our center. As you can see, we are very biomedical based, and we have four main themes, which is biomarker discovery, neuroimaging, clinical, and epidemiology. And we focus on Asian phenotype of dementia and cognitive impairment due to neurodegeneration and cerebrovascular diseases. So this is basically for me to show the types of studies that we have and the numbers that we deal with. And we have cross-sectional and cohort studies that, which some we have followed up till 5 to 6 years of observation. And we do recruit from the community as well. So at the core of our center is the clinical and neuropsychological core, where we have basically yearly clinical and neuropsychological assessments for each of our participants, where studies from biomarkers, neuroimaging, retinal, and cardiac, they all draw from the core sample that we have. And we also run interventional studies, pharmaceutical and non-pharmaceutical studies. And recently, one of the main studies that we're doing is the SINGER study, the Singapore Geriatric Intervention for the Prevention of Cognitive Decline. And we have 1,212 participants so far. So we are also part of a number of international and local research consortia. This is an overview. I'll go through the introduction of what dementia is. It's going to be a really short one. Advances in dementia research that's relevant to the studies that I'm going to explain. So dementia is not a single disease. It's actually a syndrome to indicate a decline in cognitive function. But the main thing is that it has to be severe enough to disrupt your daily life, which is your function. And it is caused by various brain disorders. The top two causes of dementia is Alzheimer's disease and vascular dementia. So in the Asian phenotype, we know that the percentage of vascular dementia is probably higher in the Asian populations than in the Western populations. And common symptoms are not just the cognitive symptoms, it's also accompanied by mood and personality changes and social withdrawal. So with aging population, there is an increased prevalence, complex care needs, which leads to economic and caregiver impact. And we also know that dementia disproportionately affects underserved and disadvantaged communities. So there are some research and prevention gaps. There's still no cure, limited treatment to delay the progression, and effective strategies for prevention and intervention is really needed. So the focus of many of the dementia research that's available in the literature would be on the mild cognitive impairment stage, which is actually the at-risk stage for dementia. Not everyone with MCI will progress to dementia, one in 3 persons within 5 years. And it is common in older people, 12.5 prevalence in Singaporean seniors. So the early detection of MCI is really crucial for timely intervention. And with Singapore's push towards healthier SG, this becomes even more relevant on how we detect MCI. So for the prevention of dementia, I'm not sure if any of you have actually seen this report. This is the Lancet Commission report that just came out this year, I think July 2024. And it's an update from the 2020 report where I think the 2020 report says 12 modifiable risk factors for 40% of worldwide dementia. Now, with the current evidence, the authors have concluded that there are 14 modifiable risk factors which account for 45% of worldwide dementia. And the risk factors are less education, hearing loss, high LDL cholesterol, this is a new one, depression, brain injury, physical inactivity, smoking, diabetes, hypertension, obesity, alcohol consumption, social isolation, air pollution, and untreated vision loss. Untreated vision loss is also one of the new risk factors that is concluded from this update. So as you can see, there are a lot of modifiable risk factors that studies can actually focus on. And we know that multi-component lifestyle trials, they actually work better than trials that only target one lifestyle component. And one of the pivotal studies is the study from Finland, the FINGER study, which is a 2-year multi-domain intervention of diet, exercise, cognitive training, and vascular risk monitoring Plus, actually, they also included social interaction. So there's that finger, the five-finger intervention. And in this study, overall cognition improved by 25%. It's a follow-up study for 2 years. They recruited at-risk seniors who are not demented, but at a slightly higher risk, slightly higher vascular risk. And they followed them up for 2 years. And if you look at processing speed, right, it's at 150% greater improvement. Actually, as we age, one of the domains that really deteriorate is processing speed. We retain most of the other functions. So with this study, they showed that there are some improvement across most of the domains and overall cognition 25%. So with that, we in Singapore also have a similar study because this pivotal study has started a whole network of similar studies that focus on multi-domain interventions on lifestyle and to prevent cognitive decline. I will talk a little bit more about that later. So as we look in early detection, this is a pathway that is envisioned by a group of experts in dementia. And they feel that the future should be that it starts with prevention and healthy aging. And the prevention should focus on all the lifestyle activities, followed up by all the symptom detection, treatment management, and all of these should utilize all the advances that we have already achieved in the detection of dementia. Because currently, how we assess dementia is via a panel of tests, blood tests, neuropsychological assessments, neuroimaging, which is via PET and MRI, cerebrospinal fluid, blood biomarkers recently. They are able to measure the tau and amyloid as per what cerebrospinal fluid previously could measure. And also the emergence of digital technologies which measure cognition, sleep, mobility, psychology with the least intervention. So, however, we also have to look back into some of the issues if we want to focus on large-scale early detection, especially in the stage of MCI. In primary care, there is a lack of physician support training and time. So a local study, the studies in Singapore have shown that GPs, they actually are unsure of what to do if somebody is diagnosed in that stage because there is no treatment previously. And if you recommend them to do all these lifestyle interventions, there's no real way to keep track for them because it's not in the medical pathway. So that's one. The health system resource constraint because the tests that we use to assess cognition, especially neuropsychological assessments, it takes about an hour to an hour and a half. And then you also have a functional assessment using the clinical dementia rating scale, which takes another hour, and it's really expensive. So people fall back on some of the short screens and assessments, but the short screens and assessments are really very insensitive to pick up MCI. They're good at picking up dementia. But the problem is, if you pick up dementia in the primary care or in the community, they're already demented and let's dial back, there's no cure for dementia, right? So, and there is also a concern on the sensitivity for the detection at this stage because it might create stigma. And we also do not know what is the acceptability of our seniors towards screening, especially in the community settings. So with that said, I'll bring you to the topic of my talk, which is on community engagement. So I'm just going to briefly go through some of the levels of community of engagement and things that we need to bear in mind. Because if we are to translate some of the evidence that we have into implementation, we need to engage with the community. And these are all the different levels that we can engage. And if we move towards the right, from inform, consult, involve, collaborate, and empower, the more leeway, the more say the community will have. Inform and consult is basically you get some feedback and there's some exchange, but the community do not have that decision-making factor in your project design or your program design. involve and collaborate, they have more say in the decision making. And empower is when the community actually self-drive and move the project or the program along. And for sustainability and maintenance, I think the part of collaboration and empowerment is really important. So for community engagement, if we look at it in research settings, it is great because once you engage with the community, it can help in increase recruitment and retention. It gives you a nuanced understanding and interpretation of research findings. And for translation of research into practice, we must be relevant to community needs and culture. And that involves building trust and relationships, capacity building of your healthcare providers, and involves a lot of feedback and reiteration as a feedback loop into whatever program that you have. So one good example that I have observed in Singapore is this dementia-friendly Singapore community net framework, where I can see that there are a lot of efforts being spent on community engagement. And you can also see that certain studies in the literature, they're already getting feedback from their participants and healthcare providers. And there are some studies that actually went on to co-create and co-design programs for the community that they're targeting. And the studies, SINGER is the Singapore Geriatric Intervention Study to Reduce Cognitive Decline and Physical Frailty. This is a typical biomedical efficacy study. All right, we were supposed to recruit 1,200 participants and to divide participants into a self-guided intervention and structured lifestyle intervention, where for the structured lifestyle intervention, we have a group of live health coaches to coach our participants on diet, on exercise, and they also go for vascular management courses. Plus, there is also a segment for cognitive training, electronic cognitive training, and also knowledge and awareness sessions. So participants are followed up for a total of 2 years, and they are measured every year for their clinical neuropsychological assessments. And this study actually involves a multidisciplinary group of investigators, and we are also investigating blood biomarkers, health policy and costs, and brain and retinal imaging alongside the traditional clinical randomized clinical control trial. And for this study, we formed a number of partnerships with regional and district health. We collaborated with the Queenstown Health District when we were in the initial stages of our recruitment. And that really got our recruitment running because we started in the middle of COVID. So it was really difficult. But at the same time, we also had to adapt most of our interventions, which is supposed to be done face-to-face, in digital settings. So at the end, each of our participants actually get a tablet, all right, for them to assess Zoom classes, which is about 80 to 90% of most of our interventions, with some face-to-face sessions for some activities that we have. And currently, as I mentioned, we have a total recruitment of 1212, 2 recruitment sites, and our imaging and blood biomarker studies are ongoing. So we have cognitive group talks. We have computerized cognitive training, where we have an app and we ask them to log on and practice at least twice a week. There are exercise group on Zoom, and we also have face-to-face sessions where they come to the gym, where we train them for their muscle strengthening for a number of sessions. And diet group talks, diet individual, and vascular risk management. So the way the structured lifestyle intervention group works is that in the first year of intervention is when it is the most intensive. And second year, we are actually looking at whether they're able to maintain what they did in the first year. And when we look at the demographics and the baseline characteristics, we can see that it is not very balanced because we had a lot of self-referrals after the first rolling in. So we've got an overwhelming majority of Chinese, and our participants are also significantly well educated. 30% of our participants are actually tertiary educated and above. And we understand that this is really not reflective of the general Singapore population. But we are able to recruit participants that we want biomedically because they have poor lifestyle habits, 70% cognitive activity and physical activity they don't really do. poor diet, 62.9%. And when we look at their hypertensive state, actually about 70% of them are hypertensive, and nearly 60% of them are overweight or obese. So socio-demographically, we are not able to get that representation, but we are able to recruit participants in the risk group that we needed for the trial. Yeah. So then when we look at the adherence to study activities, we looked at every single intervention activity that we have, which are the 7 main groups, and more than 70% of the participants are at moderate to high adherence across all activities. But when we start to profile our participants using latent class analysis, you look at the visual representation, about 62.1% of participants are in high adherence across all activities. 23.9% is moderate, and 14% is low adherence. But what's interesting is that if we look into the different activity groups, right, in the low adherence group, they do have some preference for certain activities. And these are actually the activities with which lower load on them. It is not so complex, and it has a face-to-face element where they are able to interact with somebody at an individual level. So recognizing that, we also expanded our study because we are going to turn our study into an observational cohort after we end the 2 years. We already have funding for this. And instead of also just measuring the health outcomes at every year, we are planning to do purposive sampling for in-depth interviews for our participants to really understand the barriers and facilitators to the different adherence levels that they may have in the first 2 years and in the maintenance in the next 2 years as well. This is going to be for another, we're going to measure 2 more visits, year 4 and year 6. And we are also going to recruit community organizations and community healthcare providers to have a focus group discussion with them to also understand the environment that our participants are in. Yeah. So for early detection, we had the opportunity to work with the community nursing, with the Regional Health Systems Office, because they have community nursing posts in each of the, most of the active aging centers. So the active aging centers, they actively recruit their members to the nurses if they need any chronic health management or if they need any referrals into the system. And the nurses do all sorts of things there. They count their medications, they link them up back to referrals, and they give health promotion and health advice. And they also refer the seniors into any health screenings if they, as they need it. All right. But because community health post is also invested in early detection and prevention of diseases, they have also they also do some assessments on cognition, but their assessment tools are actually not sensitive enough to detect MCI stage, and they cannot afford to use the more complicated tools because of the technicalities involved. Hence, the detection rates are really low, and by the time the cognitive impairment is noticed, patients are already demented. So that's the reason why the detection rates are still low. And we have actually worked before on a short scale called the Quick Dementia Rating Scale. It's just a 10-question, self-administered, and participants can actually answer it by themselves within 5 minutes. And it seems to have a really good performance in terms of identifying MCI compared to, let's say, AD8 or MMSE, the other 2 types of tools that are available. And as you can see, 42 out of 61 compared to 18 and 22. And the overall accuracy is also a lot higher, even if you are detecting for dementia. So what we did here was to run an implementation type study to determine the feasibility of implementing QDRS in the community. But we are also taking into account the feedback from our CHP nurses. And at the end, we will also try to work with the CHP nurses on suitable pathways of referrals and to also come up with the information education materials for the CHPs in order for them, if they do detect MCI in the community. So positive cases are actually referred to as per CHP protocol. So other than doing QDRS in the community, we actually invite our participants back to run a full neuropsychological assessments to also do the validation within the community. And these are our baseline characteristics. As you can see, it's a little better than what we had for Singer. The education for secondary, for diploma and above, it's only 15%. It's more reflective of what I think we can find in the community. They're also slightly older, but at the same time, they still have some moderate risks as well. So nearly 60% of them are overweight and obese, and most of them have hypertension and hyperlipidemia at about 50% of them each, and diabetes is 24%. So we also administered a survey on the acceptability of regular screening for Alzheimer's disease to understand if community seniors would be acceptable to be screened. So what we can see is the increase in the complexity of the procedure will decrease the acceptability. So as you can see, I would like to be tested for the presence of Alzheimer's disease on a regular basis with a short questionnaire. 95% said that they somewhat agree and strongly agree. Tested for the presence on a regular basis with a blood sample, 82.5%. It goes down a little bit. And like to be tested for Alzheimer's disease on a regular basis with pictures of my head, which is the CT scan or MRI, it drops to 61.7%. So, so we know that if it is a simple procedure, they don't mind testing for it. And if we compare between examination for Alzheimer's disease or versus colon cancer versus depression, the acceptability for screening for Alzheimer's disease is higher compared to depression and colon cancer. So this is actually quite good news for my colleagues, Mitchell Lai and Joyce Chong. They have been working on the blood biomarkers for detection of Alzheimer's disease, and they have already worked out a cutoff for p-tau 217 for amyloid PET positivity, because amyloid PET positivity indicates the presence of Alzheimer's disease in the brain. So in our next study, we are planning to work together with selected AACs to co-develop the set of interventions that we have so that it can be implemented in the community. Because what we observed with our seniors is that when we tried to recruit in community centers in the beginning, many of them refused to join because they are really afraid of using the digital technology. They have no Wi-Fi at home and all sorts. So, which is why we ended up with the demographics that we had. So that's one of the things that we wanted to do. And we also wanted to develop and adopt an efficient and evidence-based screening algorithm based also on the experts' recommendation on the chart that you saw just now, which is going to be a combination of short assessments with a blood biomarkers test to see if we can actually detect earlier, and what is the support that primary care providers would actually need for that in developing a sustainable pathway for these types of detection. So we've submitted for a grant, but we have yet to hear from them. So challenges and opportunities to integrate research and community. It takes a lot of time, especially in the engagement and the co-creation and co-design. There are also resource constraints, and there is variability in community needs and perceptions. So I think the selection of your community is also quite important. But it is an opportunity for us to create partnerships among researchers, healthcare providers, and community organizations. And it's also important for us to be able to tailor specific interventions to meet the specific community needs. And we are also able to enhance education and awareness about dementia, particularly also about mild cognitive impairment, because I think the awareness of that is quite lacking from our experience so far. That's it. So these are my colleagues and all our collaborators. Yep.
Thank you very much. Just curious, do we have an idea about the lost productivity as a consequence of either minimal cognitive impairment or going on to dementia? I mean, are we able to put a dollar value and get a sense of how large a burden is? I mean, because there's indirect costs of caregiver
Okay.
burden and those.
So for the studies that we have,
Yep.
we are actually we recruited non-demented individuals.
Yep.
Who
Yep.
are at a slight, who are at a higher risk of dementia,
Okay.
but they are still fully functional and independent in the community. So we won't be able to measure that.
Gotcha.
But we do have a group, the group from HWS, Prof. Macha and his team. They are doing some assessments on the health economic side. So maybe we'll be able to hear some news from him.
Okay. And you had mentioned that Alzheimer's it makes up a smaller fraction than vascular dementia.
No, it is still the largest fraction. So it
Alzheimer's
is,
is.
yes, it
Oh,
is
okay.
70 to 80%. And in some populations, 90%, but it's slightly lower in Asian population. Vascular is about 20%.
Okay, so the Alzheimer's, you talked about the tau biomarker. Do we have a comparable biomarker for vascular dementia? Other than the
No.
presence of that?
Yeah, it's all the presence of.
But it's not going to be a blood test, it's going to be imaging or some other.
Yes. So it is important for us to also highlight the different etiology of the disease, because right now there are treatments targeted at Alzheimer's disease that's coming out. Last year itself, I don't know if any of you have heard, in 2023, one of the drugs, lecanemab, for the treatment on delaying the progression of early dementia, has been approved by HSA, but it's really expensive. But we expect that to have more and more advancements, which is why it is important for us to be able to also detect these at an earlier stage, because right now they're testing that same drug in participants, in people who has the AD, but not symptomatic yet. So at a different earlier stage, because you don't get symptoms. It can be 10 years before you start getting symptoms, even if you have the AD pathology in your brain.
Questions? Yes, sir.
A very fascinating study. I learned quite a bit. I was wondering whether you would be interested in building a language component to your study, the early detection of MCI.
Yes.
I asked that question, also some kind of self-introduction. Lu Wen and I and other people have recently published a paper on Alzheimer's and dementia that show that actually, from looking at the nouns and verbs and so on, you can detect from natural speech, like recordings of ordinary speech, signs of amnestic MCI,
Yes.
not non-amnestic MCI.
So for the
Recently, we are now putting together a paper on the voice qualities of the same recordings that also show that amnestic MCI have much higher voice instability than controls, and then non-amnestic people. So amnestic, of course, leads to Alzheimer's disease. So I was wondering in your study of your patients, whether you have, for instance, recordings of these people and the language data that probably, if we can take a look at, would be very good.
I'm very happy to hear that, because for the pitch study, we do have a speech component, and we have recordings on certain tasks, because we had a senior research fellow who wanted to work on it. So maybe we can link you up, because we already have those recordings. And one of it is a narrative task as well. So, but what's the challenge was that in Singapore, we are multicultural, and at the same time, our participants, we mix languages when we speak. So the nuances become really hard to take. But we have recordings for our pitch study, the early detection in dementia. And we're happy to discuss collaborations.
Very good. I would take a look at it. Possible to
Thank you.
I personally believe that the language intervention is possible.
Yes.
And it has not been done in the literature. I've searched through American literature that had some work done on the linguistic markers of dementia and early stage, especially MCI. And then in our work, we did find some early signs of let's say AMCI, and which will make early detection very, you can isolate. You can sending a few pieces of recordings, just like 20 seconds, and then we will be able to probably look at the voice qualities and see whether that person is at risk. And then further, for instance, assessment may be needed. That might be a possible to speed up the community-wide assessment.
Yes, please. Yes, please. We should connect after this, because we, like I mentioned, we have applied for further funding to do the early detection using blood biomarkers in the primary care. So if it is just another recording, and we can actually record it when participants are actually doing their long neuropsychological assessments, it's not difficult to get the recording, but the difficulty is to get people to analyze and interpret. Yeah. Yep. Yes.
Oh, thank you. Just similar as Professor Bao, I also seek for chance of cooperation. This is very interesting research. Thank you. I'm just because in your slides I see at least 10% of people say, "I want you to do the test. Do you think you want to join us?" I think 10 to 20%. And this is quite an amazing number because these people already be recruited by your project. They still say, if you want to do tests on me, I will refuse to do that.
Oh.
So this kind of a fatalism remind me of my colleagues doing breast cancer. This kind of fatalism, no matter what, I just don't want to do tests. So as a sociologist, we are very interested to know who are they, and therefore to inform the policymakers.
So basically, our participants are actually from the senior activity centers, the AACs, and they are usually there to do activities. So which is why they're quite open. But I need to caution you as well, because for AACs and in my interaction with them, they always have a group of standard participants who will always come, and those who don't come will never come. So, so if you're able to, by running surveys in AACs, you are only basically targeting their active pool.
Exactly.
Yeah.
So even in that active pool, 10% of them say, I don't want to do tests. That's quite amazing.
Yes. Yes.
I think the real number will be way larger than this.
Definitely, especially because one of the difficulties with the AACs is that they, like as per mentioned, they don't tend to service the private condominium areas, even if it is within their neighborhood. One thing from my observations in the Singer study as well, because we managed to recruit quite a number of people with a higher SES, and they actually have a lot of their own resources. These are still independent seniors, and sometimes when I see my colleagues, my interventionist colleagues, when they are doing their Zoom sessions, you can see the seniors. They are actually somewhere in the UK or the US and attending class.
Sorry, Dr. Guan, just a very short question to confirm with you. Am I right that in your test and recruitment, it is very rare for the couple to join together?
No, we do have couples who join together.
How large is the proportion?
I need to check.
Okay.
Because we did not specifically keep track, but we are able to pull.
Okay.
Yeah.
Because I mean, as a sociologist, we just wonder, like, because it's usually the wife, and then the husband will refuse to go. They have another circle.
Yes, we have couples who they join together, and then one is more active and one is less active. Or you have the caregiver wife or the caregiver husband who's always dragging the spouse wherever they go. So, but We also have instances in the case because there's a segment of our study where we actually give the strengthening sessions in the gyms. We have a partnership with Active SG and Her Solutions, which is the air pressure machines, strength machines that you see in many of the Active SG gyms, which is specifically for seniors because it's easier on their bones and their muscles, while having that the same amount of strength as per your typical machine. And we train our seniors there. And what we actually see is that some seniors, they bring their spouses who are not part of the study to exercise along. So they'll be doing other things while the spouse is actually doing the activity for our program. Yeah, and sometimes they bring their whole family, like the daughter and son will be doing something else. So it's quite nice to see.
Please.
Yes.
Thank you for the great presentation. Just a quick follow-up to the last discussion. Do you like that the couples or the people who know each other in your data that introduce some dyadic components into the data, some heterogeneity that might capture actually the social factors, right? The couples might talk about this intervention. They might one's doing it might encourage the other one. So
Yes.
is there way to test that in the data or?
No, because it's not designed that way. But what we can actually do is when we are sampling for our in-depth interviews, we can actually purposefully sample a few of them to see what is actually going on. But there is no way for us to quantitatively do that. Yeah. Yes.
Questions? If not, thank you very much, Dr. Yap.
Thank you.
Hey, thank you for staying this long, and I realize I'm keeping you from your snack, so I'll try to keep on point. I'm going to chat with you about a rather ambitious project, which is called the Health District of Queenstown. Many of you have heard of it, some of you may not have, but let's just try to chat about it. I'll give you an executive summary, so if you nod off after the first couple slides, you'll be okay. You'll have gotten the gist of this. So we know the demographic change is accelerating, particularly in Asia, and it impacts all components of society. Many people see this as a bad thing, but we look at it as a positive thing, and it's an opportunity. Health span, there's sufficient empirical data that health span can approximate lifespan when the determinants of health are optimized, not just the social determinants of health, but particularly the social determinants of health. And to benefit from this opportunity, this demographic change, that society should really recognize that fixing one component, a determinant of health is not going to make the problem better, make people healthier longer. It's a complex system. It needs to be approached from multiple angles. We need to, as a society, remove hurdles to allowing people and enabling them for them to live purposeful lives. And we need to start early. We can't wait until retirement age or 55. This needs to be a life course activity. So the Health District at Queenstown Project, who's the co-leadership, is a statutory board, Housing and Development Board, NUS and NUHS. It aims to shorten that illness period, to shorten the gap between health span and our lifespans, enable purposeful longevity, and promote bonding intergenerationally, and allow people to age in place and to be welcome regardless of their age. The hypothesis is by approaching this as a complex system, we can improve healthy longevity via co-designed initiatives. We can establish causation and not just correlation, and we can weigh what different initiatives have their impact on the improved outcome. And with those effective interventions identified, we can then, through continuous feedback in subsequent iterations, achieve a greater impact. It may be ambitious, it may be naive, but that is the hypothesis. The methodology is to do attack the various determinants of health which are amenable to addressing. We're not looking to change someone's genetic code. We're not looking to modify too much the healthcare system, maybe change the way we deliver healthcare, but we are looking to change some of the other determinants of health. We're looking to find and develop interventions which are co-designed with the residents, because obviously we want them to accept what interventions are taking place as opposed to be imposed on them. We want this to be a grassroots process. We want to be able to objectively measure what we're doing, and it needs to be not just effective, but we need to be able to afford it and scale it beyond Queenstown. So the background, that's it. You can nod off now if you like, but we'll go into a little more detail. We all know that we didn't live very long for the first 100,000 years as Homo sapiens we were around. It's just since the 1900s that we've had this revolution to where in Singapore anyway, we're female 88 and males 74. And if you break down a little more recently, you can see this was around 1920, 1910. And this big jump, lots of reasons, public health, sanitation, medications, change in industrialization, et cetera, et cetera, et cetera. And Singapore, continues to be a world beater there. But we're not reproducing. We're certainly doing better with regard to our length of life, and we're not reproducing for many, many reasons, most of which you know better than I. And now, as a result, there are more people over the age of 65 than less than 5 years old. So this demographic change, if you look in the West, it took 115 years to go from being an age society, 7% of the population, to 14%, and another 30 years to go to 21%, a super age society. Singapore, we did that first jump in 20 years, the second jump in 8 years. And in Asia, across the board, much quicker than in the West. And you can see in Brunei, they'll go from an aging to an age society in just 13 years. So who cares? So what? Well, as you all know, it impacts all components of society, economy, community, and families in all of these very different ways. It forces us to reconsider how we allocate resources. Maybe we don't need to build as many primary schools. Maybe we need to change how our transportation works, but it impacts across the entire spectrum. In Singapore, I spoke about this as our lifespan, but this is our health span. So for women, there's a 12-year period where they're in less than good health, and in men, it's approximately 10 years. This has significant impact on resources for the entire society, but this is just healthcare expenditures. There's also a lot of indirect economic costs of people being in poor health, the usual issues here. But it's all not lost. We think that if we allow people, encourage them, enable them to live longer in health, and that's physical, social, mental health, they can continue to contribute. We need to allow them to contribute. And I apologize, this is a metric, but it's, as mentioned, we can exploit data for our own purposes. So this is from 2003, 2004. They just asked the different deciles. Do you have any health-based limitation in your ability to work or do housework? And so the purpose of this, you can see people up into their 85 plus, 50% of them were still able to perform these activities. So they're capable of doing this, but are we allowing them to do it? And not just physically constraining them from doing it, but by policy and by culture, are we inhibiting their ability to continue to contribute? These are the determinants of health. Again, I think these are known to everybody. I've spent my professional life working on this, which has such an insignificant part of people's well-being, but nevertheless, it's been a good life. But we're interested in all of these things, and just to break down the social determinants of health, at least this list of them, because we wish to attack these all simultaneously. And the reason we want to do it simultaneously is that health is not a simple one-step process, one barrier to it. It is a complex system, and all of these things, if not all of them are addressed, then we'll get less than optimal outcome. Obesity was just used as an example. So in the health district of Queenstown specifically, this project, our goal is to narrow the health span lifespan gap via initiatives, as mentioned, across multiple determinants of health, and try to determine their contribution. Once we find the effective, particularly the most effective, then we can validate those in a different area of Queenstown, and then hopefully continuously improve them through rapid iterative cycles and scale them up throughout Singapore. The reason we picked Queenstown, there's several reasons. Number one, we're in Queenstown. Here we are over here, and Queenstown is over here. And it has the demographics of what Singapore will have in 2026. 100,000 people, 80% of them live in public housing. It is a prototype of Singapore. And these are the way we structure our operations, our thinking. Now, these different work streams, these are all work streams. They work together, they collaborate with each other, but they're just our way of thinking and organizing some of our work. But these are the effector arms, essentially, the preventative health and care delivery and purposeful longevity efforts. But we're HDB leads the built environment and how it impacts people's well-being. We have a technology arm. Shanghai is involved in our communications and engagement. And overall, we have an evaluation work stream that's trying to really set up a very strong way of assessing the impact of what we're doing. The Basho principles are, which I'll speak to in just a moment, are guiding guiding us in how to go to co-design, and we're also using behavioral implementation science to get people on board. So these are the different work streams. I'll just give an example or two of each of them to kind of close off the talk here. This is just a sampling. We have work stream one, which is again preventative health and care delivery. We have a blended care team. We have these other projects you can see as well. And this is also to try to stimulate interest in the audience. And in the purposeful longevity, I'll show you a couple of these in just a minute. We have the Abasho hubs and a tri-generational engagement program. I'm interested particularly in older individuals being able to work, have that not the physical availability, but the policy availability and the employment opportunities to do so. So the blended care team is part of our preventative health and care delivery work stream. It's embedded in one of the public housing. It's similar to a community health post. We've got a variety of folks either present or readily available. We have social services available, and we work closely with our volunteer welfare organizations, and we have a shared common information system, and we utilize implementation science. So we're trying to determine of a particular teamlet of people in this embedded in a, let's say, a rental block, how many people they can serve. Can we identify everybody there that needs to be screened for their social, psychological, and physical well-being, and how many can a team serve? So that's part of the work being done. The Abasho principles, you may or may not be familiar with Emi Kyoto, the founder of Abasho, but it takes the principles of elder wisdom, normalcy of people being together, avoiding demarginalization, ownership, being multi-generational, and embracing imperfection as a way of empowering especially older folks in the community, but everyone in the community to be involved instead of being passive and allowing government and agencies to do things to them and for them. And as far as intergenerational engagement, we're trying to get programs that go both ways. Here, they're older individuals are teaching young about Mahjong, and here doing a little technology phone app education for the older folks. As far as the built environment, I'll show you some programs in just a minute. In technology, we're trying to figure out how it'll leverage the services that already exist and how we might be able to reach places where we cannot currently reach to help people to decrease or to allow them to continue to live in the community. As far as housing goes, the built environment, we're looking at both the housing unit, we're looking at the block, and we're looking at the community. So just looking, HDB is interested in exploring these things in a bit more depth, a bit more rigor as far as how their technology can be integrated. And this is in the neighborhood. They're trying to figure out how to plan to make all of this more accessible. There's also some interesting work being done on how can you decrease the ambient temperature in an estate through a variety of architectural and urban planning strategies. As far as technology goes, we've got a variety of things that are currently being tested. This isn't meant to be comprehensive. This is just meant to give you a smattering of what's going on. I think there's an enormous interest in technology being used to help people stay and age in place. I'm bit of a skeptic, to be honest with you. I think a lot of things like fall detection, in my mind, once you've fallen, you've fallen. I mean, it's nice to find you, but you've fallen and you've either bled or you've had a broken hip or something else. So this is a fascinating area in ambient intelligence. It's looking at AI to be able to predict future events, whether it's a fall or something else based on your current movement and patterns. So this is an interesting program being done with Stanford, Li Fei, who is there, and the grandmother of artificial intelligence. As far as evaluation and communications and engagement, this is a baseline study. We've looked at 5,000 folks. We've completed this study. The analysis is still underway. It has not been published. But some very interesting findings about the needs, wants, gaps of the folks, the residents of Singapore, of Queenstown, and it's of people either 18 to 95 or 21 to 95, and it oversamples minorities to make sure that we have adequately powered the data so that we can really get a good reading. It's been extremely informative, and it will help us co-develop subsequent interventions. We'll go back and sample them again in the future, and we have a control community. So this community is Queenstown. We're going to have interventions, and we're going to see the impact of the interventions. This will be our control community, which will allow us to see the normal activities that are being done outside of Queenstown for all of Singapore, what impact they have on people's healthy longevity. As far as the health district evaluation framework, we're looking at 5 domains. You can see them here, and we have 40+ indicators and lots of different metrics on each of these to try to really drill down and establish this as being based in science as opposed to experimentation without any sort of endpoint to assess. In communications and engagement, developing a narrative, addressing issues of ageism, that people can empower them to think about how they want to be as they age, take responsibility for themselves, and from a society perspective, unleash this capital that is maybe not completely unleashed at this point in time. Also, to find the appropriate effective communication channels for whichever cohort we're working with, implement a campaign, and then assess its impact. There's a steering committee that is involved in overseeing Health District at Queenstown. Again, the leads are NUHS, NUS, and the Housing Development Board, but we have all these other bodies, including philanthropy, and other entities within the government who are actively involved in giving us guidance. We have an advisory panel, and these folks, their names are less relevant than their academics and social scientists, psychologists, architects, et cetera, to try to address all of these issues. So in summary, the aim is to accelerate the virtuous cycle of healthy longevity. We believe if we can address issues of the social determinants of health, work, the built environment, the healthcare delivery systems, we can get rid of the enablers, that we can unleash healthy longevity, allow people to live productively, purposefully, and in good health, which will then benefit society through the increasing human, financial, and social capital. Again, works this way. And the reason it's going to work in Singapore, we're fairly confident, is because we have an explicit social compact. It's on the web. You can find it. So Singapore Social Compact. And this really is the catalyst for all of this working. So thank you very much for your attention. And if anybody's interested in working in this unique platform, we're happy to have a conversation. Thanks.
I'll help you chair this part of the Q&A.
Thank you. Myself a question.
Any questions for David? You're part of this study.
David, I want to ask you because I'm part of the proposal aging part, working with Ling. So I think that's a very innovative idea. Like, I just want to see like how proposal aging, this project is integrated into the other part of the research. Like, if you find out something, how we could like cooperate with other team to develop an intervention.
Well, they serve as folks to get who we try to co-design, co-develop other projects with. What I think the trick for me, not being a social scientist and not being a community organizer, is understanding that development of developing a relationship and developing trust. Because once we do that, which takes time, then we can get them involved in, would you like to be involved in a basho? That's a great way to spend your afternoon, get to meet some interesting people. Would you like to be involved in our satellite office and do some volunteer work? Would you like to be a health coach and get involved in activities doing that? Or would you, by the way, we have this blended care team. This is a way to integrate you into that. So they're cross-fertilizing each other. How effective that's going to be and how organic that's going to be, I don't know. I think what concerns me is many things we often do in research is we want to prove a point. We have a hypothesis, we have an intervention, we want to test, we do it, we get the results, and we go adios. So I think the trick is getting to transition this to where it impacts longitudinally. So I don't know that I answered your question directly, but that's the thinking.
And also another question. So David, along this line, because health district is a very innovative model. I remember it was kind of inspired by some Japanese practice. Singapore also recently have this healthy SG movement. Some models also rise up. As Dr. Yap may familiar with this community of care, COC model. I also see some literature rising up. So how do you kind of compete with other kind of models?
We're trying not to compete. We're trying to integrate those things. We're not looking to replace policy or schemes or programs, not at all. We're trying to figure out how to turbocharge them. How can we take those ideas and expand them more? We know, for instance, in Healthier SG, it deals, it's got already issues to deal with physical health and plans to deal with mental health, but no real stretch into social health. So how can we augment that program?
So maybe David, I've also done this other project at Dawson, which is part of the Queenstown area. And this is, my project was on the older adults who were relocated under SIRS from Tanglin Hall and the adaptation in Dawson, right? And again, so this goes back to this idea about aging in adults that we were talking about earlier, because the approach of the health district has been to focus on a particular locality. And of course, it makes a lot of sense to kind of enrich facilities and the services within a locality. But when we did GPS tracking with the older adults, about 41 of them, we did 7 days GPS tracking and then follow-up interviews to actually trace their social networks, where do they go to. I think for us, perhaps the GPS tracking, tracking, Freudian slip, we tracked them, right? Enabled us to really see their mobility patterns within the Dawson area. what kind of services they use, amongst the 5 precincts, where are the places that they tend to go to, etc. But what was really interesting was the GPS tracking also showed us that almost half of those, right, they would make regular trips back to Tanglin Halt in order to use the wet market, to use the hawker center, etc. That's unsurprising. I think what was even more unsurprising because it's out of nostalgia and familiarity. But what was even more surprising for us, right, was many of them actually also exhibited patterns of going to other nearby housing estates for their activities. So for instance, in Dawson, they said there's no wet market in Dawson. So they will go to Ghim Moh, or they will go to Red Hill, and even Bukit Merah. And so part of their experience—
For commercial reasons or for social reasons?
Both, yes. So they went, to look for services which they felt Dawson could not fulfill their needs and desires. But they would also, for example, go to our community center activities in these other nearby neighborhoods because it expands their range of choice. And more importantly, it was, number one, a way for them to explore, with their family and their former neighbors, kind of new parts of Singapore to them, right? Of course, Red Hill, etc., would have been familiar to them from their time living in Tanglin Halt, but moving to Dawson actually gave them a greater impetus to explore beyond their immediate neighborhood. But the other thing was also, sometimes they would say, it's our friends who bring us to all these other activities because they stay nearby there in those places. And so, we decided to go with them. And so this is what we meant by actually tracing their social networks reveals their wider geographies, right? So I feel like, there's this tension because of course we do want to provide aging in place as a positive, experience for functional reasons, as well as for people who, when they're later in life, they may not be able to commute so much, for instance. But yet, the actual life experiences are also showing that older people are traveling far, they enjoy it as part of their physical activity, as part of enriching their social networks, right? So my question then is, we invest so much resources in trying to create this idea of aging in place, including this impartial idea, etc. But can we really do this for every neighborhood in Singapore? And can, so one policymaker ever said to me, actually, your idea of aging in place makes me feel that it's even more important for us to have more diverse and better services, within the neighborhoods where people stay. So that's one line of reasoning. But my counter challenge then is, or counter argument is it really the best way for us to move forward? Because can a single neighborhood have that full range of services and facilities to meet the needs of every single person? So I think, what I'm proposing instead is actually we need to look at our neighborhoods, our precincts as interconnected. So we jointly advertise, different kinds of services, activities, and then people will just flock to where it's best for them, right? So it gives them choice. So I just wondered, what's your thinking on this now that I've thrown up this other way of thinking about geography?
So I agree with you. I don't think one size fits all. I don't think Yabashu is replicable in every community. There may be others that it is replicable, but I think there's other organic projects such as Holland Village Little Library or Queenstown Kakis. These are groups that pop up. But it may be the normative once people start hearing about these things and saying, maybe I want to find my niche, my place. So I agree with you. I think trying to replicate everything in each site is very top down and really not going to meet the people's needs.
So in a sense, health district is kind of like an experiment, social experiment, right? To see what kind of facilities, models, could fit in this one. But then equally, we still need to maintain an openness and in fact, actually encourage older people to be active and mobile.
Interesting enough, part of the survey, which hasn't been published yet, was a sense of safety very, very high across all ethnicities, across all ages, across everything. But sense of trust. Can you trust your neighbor? Can you trust your community? That was shocking.
Yes, that's
So-
interesting. Yeah.
Yeah. So how do you build that sense of community where I feel safe, but I don't?
Actually, in our own survey, we did a survey of 1,200 older, nearly one dropped out to see. So it's nearly 1,200 older Singaporeans in two parts of Singapore. And we asked them to name 5 people. So this is a name generator approach, which Vincent Chua uses. We asked them to name 5 people within your social networks that you think are the most important. Unsurprisingly, family, of course, was named first, right? Within the top 5, right? Neighbors were named last. It says a lot, right? Yeah. So we put so much emphasis on building a community spirit within your neighborhood, etc. But are your neighbors necessarily the ones that you turn to? Right? So I mean, I've been kind of sharing these findings, etc. And so someone said to me, are your findings then suggesting that the kampong spirit, is diminished in Singapore? What do you think? Yes. My answer was different. I said, given that Singapore is a very compact city, transportation connectivity is so good, and digital networks are pretty within, especially, the future old, right? Their digital literacy is becoming stronger. Instead of thinking that the kampong spirit is diminishing in a particular neighborhood, should we instead be looking towards an enlarged kampong spirit that's connected across neighborhoods?
But you can't use the internet to look after your kids when you've got to run down to this shop. It's your neighbor.
Well, but you can use WhatsApp to contact your sister who lives somewhere else to come and help with your kids, right? Or to put your kids, if they're old enough, in the Grab, to just go to your sister's home. So that's an expanded sense of the kampong spirit, I think. Yeah. Anyone else? What's the time plan? I think I'll hand the chairing back to you then.
Yes, thanks. I think we'll have our closing remarks by Dr. Nala Lee. Thank you.
So the Singapore Research Nexus, I'm going to keep this quick because lunch is outside. So the Singapore Research Nexus is really thankful for you, for our speakers and for our participants, for your questions and for your interactions, and especially thankful to David Allen for moderating. So what I'm hearing, I'm not in this field by any means, I'm a linguist, but what I'm hearing is that, collaborations between both schools and FASS, Yong and SAS would be really useful, since a lot of these health and aging matters can be contextualized locally, socially, logically, and culturally as well. So for possible, collaborations that come out of this, and whether it be e-health or whether it be measurement issues or issues dealing with preventing and measuring and dealing with dementia, using community engagement, or looking at this style project in and what we can do about increasing health longevity. We would like to invite you to think about the possible policy outcomes of these issues that were raised. So the conversation doesn't have to end here, we can keep having it. So with that, I'll close this so you can have lunch and keep talking about these things. Thank you so much for being here.
Oops.